interesting. There's lots of reasons why, but I'm going to talk today about one particular reason, and it's kind of a function of the fact that as a consultant in public health, I've moved around a lot. I've worked with many different organisations and had many different functions within them. And what that's enabled me to do is observe the policy process from the very macro, national, sometimes international level, the advocacy that goes towards making changes, and then I get to see how it trickles down and perhaps engage with that process until it ends up at the local level, when it can set up an environment where we can work on designing solutions for problems that are really grounded in the community's needs. So what I'm going to do today is just talk a little bit about two case studies I think highlight this really well. I've got lots of case studies I could choose, but these are the ones that I think are kind of like the most discreet and neat and tidy. So the first one I'm going to talk about is fetal alcohol spectrum disorders. So this is a term you may or may not have heard of. It is a neurodevelopmental condition that can affect your ability to forward plan, to regulate your behaviour, to engage in conventional social interactions. It resembles autism in some respects, but it's not autism. In fact, that creates a diagnostic difficulty because it comes up with a really spiky result when you do the test, which means it often doesn't get diagnosed, which means that rather than get a proper diagnosis and support, people just get picked as troublemakers or difficult to work with. And I'm sure you can all recognise how if you get picked as a troublemaker at school, that pushes you into labelling, stigma, you get a more crowd, criminal justice system, you're quite suggestible when you've got this condition, and you can see how that can spiral out of life. It's not necessarily dose dependent, but the only way that it can happen is when you've got alcohol exposed to the fetus. So alcohol surrounding the fetus due to alcohol consumption during pregnancy. We're not quite sure exactly when in the pregnancy, embryologically, it has the biggest impact. And even if you did, you wouldn't know precisely what stage a woman is at during their pregnancy. Which means that the only safe advice that we can give is to have zero alcohol during pregnancy. That creates a zero risk of this condition. But any alcohol elevates the risk above zero. So since the 1980s in the United States, the advice has been that zero alcohol during pregnancy is safest. But it was only in 2016 that the advice in the UK fell in line with that. Before that, it was just keep alcohol to a minimum. There's some really interesting reasons why that you might have got that policy differentiation there, which I won't go into today. But even in 2016, we actually had two different authorities giving different advice for a couple of years. We had the Chief Medical Officer saying zero alcohol, and we had NICE, National Institute for Clinical Excellence, saying keep it minimum. It was only 2018 when it actually started to align. And that was about the time I started in the Department of Health, and I was tasked with alcohol within the Healthy Behaviours team. And I was looking at children with alcohol-dependent parents and FASD. So what did we have in terms of policy advocacy at that point? We had several work streams beginning to line up, but nothing had really happened yet. There were still some gaps. So the first one was that we had an MP who had lived experience, Bill Esterson. He had a son who's affected by fetal alcohol spectrum disorders. He made a connection with the National Organisation for FASD, the main voluntary sector organisation on this condition, and they formed an all-party parliamentary group to push on this issue. They had lots of lines of argument, but the main ones were that we don't have enough diagnostic facility to actually recognise when people have this condition. And when it is recognised, there are not adequate referral pathways in place. We don't have systems to help individuals in this condition. We also had clinical and scientific expertise from several universities, and the national lead clinician, Dr. Raja Mukherjee. He runs the only clinic in the country that deals with this issue, down in Surrey. But what we didn't have is a lot of civil service support behind it. And that was where myself and my colleagues were able to step in and saying, right, there's a really powerful argument being made here. It's grounded in evidence, lived experience. What can we do to make a change? So one of the early things that I did was to develop a national needs assessment, to start to pull together all of the fairly poor quality evidence that we had, make some modest recommendations that the government could get behind without overcommitting. But the most important thing we did was to connect with NICE, because Scotland were a little bit ahead of us on this. So for those of you who don't know, although the UK has a coherent single government, there are a few functions which are devolved to the individual countries, and health is one of them. So you end up with a little bit of difference between how each individual country approaches different health issues. And Scotland tends to be able to get off the mark quite quick when it comes to policy developments. and this was no exception. So they had their sign guidance, which was quite a comprehensive overview of how fetal alcohol spectrum disorders should be dealt with. So we went to NICE, we lobbied them, and we said, we need to catch up with Scotland. There's a really powerful reason to do this. We've got politicians calling for it. Here's the science behind it. And they did listen. So a couple of years later, delayed during COVID, unfortunately, but a couple of years later, they released a NICE quality standard. I think that was 2022. So meanwhile, I finished at the Department of Health. Middle of COVID, I started in a local authority. That just consumed my life for a couple of years. It was so busy. And I thought from the Department of Health work, yeah, that was great. I think we'd made some really good progress, but that was that. I've moved on now. But it so happened that in Hackney, we had 2 counsellors, also with lived experience of FASD. They've also got children who are working through this, and they understand the challenges the families are facing. And they've been saying for quite some time, what can we do about this? This is a really important issue. And the officers previously had to say, well, look, we recognise what you're saying to us, but really what can we do? We've got neurodevelopmental support systems in place for people with autism, ADHD, and that can, and it does, support the needs of this population. But beyond that, what more can we really do? But because the quality standard had been put into place, we now suddenly had a frame of reference. We had something that we could start comparing our systems to. So what we were able to do is commit to doing a gap analysis, where we started comparing and contrasting our system against best practice and seeing what we found. So I got some of my colleagues to conduct that gap analysis, and we came up with some quite simple but extremely useful recommendations that we're now in the process of pushing forwards. So one of those recommendations was that we need better training for professionals, because there was perhaps alarming lack of understanding among people who you would expect would know this and understand this issue really well. We've embarked on a program of clinical audit with mainly the Homerton Hospital to see if women are being given the correct advice at all points during the antenatal period. And then as a longer term stretch goal, we want to start working with our regional NHS system to put in place proper referral pathways so that when this does get diagnosed, there's an established system for people to move through to give them a better outcome. So I've got a few kind of just flavour pictures here. There's some lovely work with people who have the condition by National FASD, the organisation. They've put together loads of resources to help people come to terms and understand and relate to other people who've been living through it. You've got FASD and some of their supporters, and on the bottom right there, that's the All-Party Parliamentary Group, a really powerful lobbying outfit. There's a really simple model of how we wanted to do this, because you can't have every local area with this hyper-specialist clinic. Very impractical to do that, so we developed this hub and spoke model, like centralised national expertise, which other areas can feed into with appropriate training. And then you've got the 5 pillars of the quality standard on the left-hand side. So the theme here is about how the top-level macro changes in policy fed down into a local level where we could meaningfully action the changes that have been made. And that it was just quite fortuitous. I happened to be involved in the top level stuff, and I happened to be involved in the right place at the right time on the local stuff. So it's really nice to kind of see that flow. So my second example is on a related but different issue of general point of substance use. When I say substance use, I mean harmful drug taking. Some people call it substance abuse, substance misuse. I think this is nowadays considered to be the least stigmatizing way of describing it, but it's all referring to the same general idea. Substance use services are supposed to be provided by public health teams who are rooted in local authorities. And unfortunately, over the last 10, 15 years, austerity has really depleted the skills and resources that these teams have. And as you would expect, you started to see an increase in the problems associated with drugs, deaths, physical, mental health problems, homelessness. All of these things are interrelated, and they've all been getting worse. The government was aware of this problem, and to their credit, they did take some steps to try to remedy it. So they commissioned Dame Carol Black to produce her drugs report, her drugs review, and she published that in 2 parts. And in 2021, the government listened. Her recommendations mainly revolved around better commissioning of services and improving the quality of the treatment that we're providing. The government did listen. They produced a response. A large element of that did acknowledge what was in the report, They also tend to have a slightly more enforcement-oriented political outlook. So as a conservative right-wing party, they feel enforcement is an important part of this equation. You may agree or disagree, but that's a debate for another day. But they pulled this together to come up with a 10-year strategy from harm to hope. And the core pillars of that were to break drug supply chains, to reduce the demand for drugs through education, and to create a world-class treatment service. I know world-class has been overused by us the last few years, but I think it was a laudable goal in this instance. So they accompanied that with quite a lot of funding. So we got an extra few million in our local area, but it came with many strings attached. There were lots of metrics that we had to deliver on. And we had to develop a combating drugs partnership. Name I'm not too keen on, but we did do that. The idea is that if you have a person with a need for substance use support, the fact that they would then go to your substance use support system and then come out the other side and they would have recovered, hopefully for the long term, is a hopelessly naive way of looking at this, as I'm sure we can all see quite quickly. Those issues I mentioned earlier about homelessness, adverse childhood experiences, mental health needs, rough sleeping, all of these things vastly complicate the issue. It's a knotted ball of complexity and problems that individuals with this issue need to solve at the same time. So you can't do that with one organisation. You need lots of expertise working with some kind of synergy to start to help the people that we're looking to help. So we've reached out, got a couple of amazing people on my team, and they've really done well on the networking. I've got just a few of the organisations that we're working with here in London. So Thames Reach, they work a lot on rough sleep and homelessness. St Giles, their employment. People's Recovery Project is a lived experience forum. Swim, a really nice local organisation that work with older black men who've had issues with the criminal justice system. And some of the stories that we've heard anecdotally about people being bounced around the system and just failed for decades without just going in and out of prison, never really breaking their substance use problems. We're suddenly hearing stories about how people have broken out of that for the first time because you've got a properly supported organisation that's had the resources to network with other people where it needs to, and it's really turned around some lives. That it's been amazing to see. And this is backed up by our baseline metrics improving in a way which, in some instances, made us from one of the worst performing in the country to one of the best. So one of those metrics is continuity of care. So this is when you have someone who's in prison and they have substance use support there, and then when they leave prison, they need to transition into the community services. So you would hope that would be close to 100% of people, otherwise they get lost in the system and then they're back to square one. But our score was, I think, 10 or 20% of people were doing it, so nearly everyone was getting lost, which is appalling. There were a little bit of issues with the data. It wasn't, so we corrected that, so that improved it slightly. But fundamentally, we needed to design some solutions to correct this issue. And it doesn't sound particularly innovative at the end, but it actually really is. Nowadays, we send essentially a chauffeur to the prison gate. Someone is there to collect someone on release, and they take them to their appointment where they can get their substance use needs sorted, they can get scripted if they need it, and we also happen to have a housing advisor there. We also happen to have someone who can help with their benefits. So whereas before, if someone didn't have the bus fare or had clashing appointments and didn't really have the ability to kind of coordinate that, that's all gone now. We can just bring them out of prison, get them sorted on the day, and our metrics, as you would expect, have gone really high now. So we're now, I think we're best in London and among the best in the country, and we're trying to share that good practice with everybody. A couple of nice pictures here. We've been able to invest in some community outreach. So rough sleeping and substance use has a really intimate connection. So we've created our community wellbeing team, who rather than just going out and looking for people and trying to get them the substance use support they need, they try and go to places where these people may be and create a space which is quite welcoming and appealing. So we have food, a nice coffee machine, clothes. If people want to come to us, that's great. And then maybe we can use that as a hook to start introducing them to that substance use team to maybe think about what can we do about your housing situation. Those smiles are real, they're very friendly. You've got Eric at the top wearing the beanie hat. He's the one who often goes and collects people at the gate. It's an amazing team, and even though the fact that we got this resource is actually just a weird chance. It was an old COVID vehicle that we had that we get used in the end, and we've repurposed. But the principle here seems really sound. I think we've got some colleagues here who are going to be doing a bit of analysis on it over the coming weeks. but other places are looking to this to kind of see what they can learn and see what they might be able to duplicate. So I'll draw it to a close there, but again you can see how these big changes at the national level have filtered down and created the space where we can start to develop really locally developed solutions focused very specifically on problems that we had. But we wouldn't have been able to do it if that process hadn't worked effectively. And I guess the final thing I'd say is that even though there are a lot of advocates, supporting Dame Carol Black's work and pushing the government towards getting that strategy, we haven't been successful in everything. I'm hiding a lot of mess and arguments and failures that we've had along the way, of course I am. But where we have been successful, that gets fed back to central government and the policymakers see it. And that in turn helps them make decisions in the future. So there's this reciprocal relationship, and I would argue that when you are successful, when you can deliver on things, that in itself is a really powerful form of policy advocacy. So I think that that puts a big burden on the team, but when we're successful, not only are we helping people in the immediate term, we're actually influencing a much bigger system, helping to shape it in that way. I'll leave it there. Thank you very much.